risk risk prediction or dangerousness is impossible or difficult, very difficult.
Very difficult.
But assessment, dangerousness assessment is possible. I want clarification from you.
Well, I think you can. Let me just discard some of these. Just tackling your first question, dangerousness is a term that isn't used very much now anymore. It's sort of fallen out of favour. I don't think it's really precise enough to start with. So what are you actually predicting when you say somebody is dangerous? You can assess people, obviously, but what I'm saying is that the margin, the error associated with your prediction is very great. And that has nothing to do with you. That's the point I was trying to make in this short talk. That's to do with the base rate of violence and the fact that our risk assessment prediction instruments themselves are not perfect. So when we say that, and I didn't have time to go into it, but that something, a risk instrument has a prediction of 80% area under the curve, which you may be familiar with, that means that you're right about 70% of the time. But is 70% over 50%? This may be a dangerous person in terms of concept. There is a very large margin of error, and that's all I'm saying, that one needs to be aware of this. And it becomes particularly ethically taxing, I think, when you lock up people on the basis of their dangerousness, or maybe not release them because they're deemed to be dangerous, which is what we are faced with a lot in the UK. So you have people who are at the end of hospital treatment, or at the end of a parole, of a sentence, and they go before a parole board who have to assess them and their future dangerousness. And I don't think the parole board are aware of the margins of error associated with doing that. And they are likely to play it safe, which means that people will remain in custody much longer than they need to. But if they release somebody, then they do something wrong, have a false negative, that is very serious for the parole board here, or people on the parole board. Does that answer your question?
Yes, please.
Professor, if you accept saying that every psychiatric patient is violent or potentially violent until proven otherwise, do you accept that?
I don't accept that at all, no. I'm saying that the only way in which you can avoid having a false negative, predicting that somebody won't be violent, and they are, given our inaccuracy, is to make everybody violent, which obviously is crazy. It's madness to do that. But that's the only guarantee, absolute guarantee, that you could have.
But both ways.
Both ways are wrong.
Yes.
Yep.
I'm going to say you're biased.
Yeah. That's exactly right, yeah. Whichever way you do it, it's a balance.
And there's no single or
No.
criteria for objective?
No. Sorry.
Thank you, Professor Connor. My last question, just from the medico-legal aspect point of view, at what stage and what level do I have the right to physically restrain my violent patient?
You mean on the basis of risk?
On the basis of risk, yes. Can I make use of nursing staff, highly equipped nursing staff, or security guards to physically restrain him?
Oh, yes.
Sometimes they do threat us while they are restrained.
I mean, I'm talking, blathering away here about a theoretical thing, but in actual practice, of course, you have to restrain people on the basis of them being like that. Some of them actually have been violent already.
In case of self-harm and others harm?
Self-harm, I think they can certainly be restrained, yes, absolutely. Yes. I think that the problem that you have, though, is not so much when people are actually doing something or have done it. It's actually, what we're talking about is predicting whether they're going to be doing it in the future.
Yes.
And that's the problem.
Yeah, sure.
Yeah.
Thank you very much. Now we are going to move to our next speaker, Dr. Rigi Alexander. He will talk to us this time about schizophrenia, an update on psychopharmacological management. As far as I know, the area of discovery of glutamate receptors and the hypofunctions of glutamate and NMDA receptors is so rich, and we will discover now what is the updates from Dr. Rigi point of view. Dr. Rigi?
Thank you very much. I'll once again try to do this as quickly as possible. I'm really standing in for Professor Peter Tyrer in doing this presentation. Professor Tyrer was an expert advisor to the panel which decided the National Institute guidelines on schizophrenia in the UK. So I'll just take you through a few salient points. This is the guideline update that was published recently, and once again it's freely available online for those of you who are interested. I'm focusing only on pharmacology of schizophrenia and on 8 points in the treatment pathway. So for a patient who presents with a first episode, a patient who presents with any acute episode, the advice on relapse prevention, the advice on inadequate responders to treatment, and then the use of depot, side effects, and then the guideline makers advise on what they call effectiveness, which is really routine clinical practice as opposed to research, and then a section on recommendations. Throughout, rather than going through individual studies, I'm just giving you the end point. And much of the thrust in the UK, and as I suspect elsewhere in the world, has been the comparison between second generation or atypical antipsychotics and first generation antipsychotics, so the haloperidol term. In terms of routine practice here, would you generally use second atypical neuroleptics now more often, or is it conventional atypical today? And that is a situation across the world, and even the NICE guidelines for first edition said second generation drugs should be used as a first line. The problem comes when it is a publicly funded health system where, Professor Duggan's earlier slide on value comes in. So it's not just effectiveness, but how much money does the state pay in. So therefore, economic analysis becomes important. What the NICE people did was to look at all the evidence in this area, 9 randomized controlled trials, 12 evaluations, 1,800 patients, and their conclusion was there is no difference in efficacy between first generation and second generation drugs. And that theme recurs over and over again. Acute episode. So this is any acute episode, not just the first episode of schizophrenia. 72 randomized controlled trials, over 16,000 patients, all those drugs in one-to-one comparisons. No difference in efficacy between the drugs. We'll come to side effects in a later section. So purely focusing on efficacy, no difference. Relapse prevention, over 3,000 patients. All drugs reduce the risk of relapse to the same extent, whether it's first generation or second generation. There's a modest benefit for some second generation, but insufficient evidence. For people who are inadequate responders, so inadequate responders were defined as people who did not have symptom remission with 2 antipsychotic drug trials of 6 weeks or more. This time there is a difference. Clozapine, 18 randomized controlled trials. It shows consistent evidence of efficacy over first generation drugs. But crucially, on negative symptoms, no significant differences. And those who are familiar with the marketing material that comes across our desk do see this point being made that for negative symptoms as well, the second generation drugs are helpful.